Welcome to the JASN podcast. I'm Josie Briggs, Editor-in-Chief of the Journal of the American Society of Nephrology. Each month in this podcast, we talk about one or more of the papers in the current issue, hoping the discussion will prompt you to look at some of the interesting work we are publishing. Joining me today is Tom Hostetter. Tom is JASN's Deputy for Reviews and Perspectives. He's a professor of medicine at the University of North Carolina School of Medicine. Tom, thank you for joining me for this conversation.
Well, thank you. Yeah, I'm glad to be here.
So the paper we're going to talk about today is entitled Protein Carbamylation and the Risk of End-Stage Kidney Disease in Patients with CKD. First author is Salem Kalem, and the corresponding author is Anders Berg. Tom, you contributed an excellent editorial about this work, and given your longstanding interests in the causes of uremic symptoms, I'm particularly delighted to have you join me to talk about this study. So to begin, can we admit, or do we agree, that in spite of years of work, we still do not really understand which of the chemical changes caused by impaired kidney function are actually responsible for uremic symptoms? Do you agree with that statement?
I agree completely, and my friend and sometimes collaborator, Tim Meyer, often likes to say, we're applying this to 1 million people or near about worldwide, and we still don't know what we're really removing that's important to remove symptoms like nausea, vomiting, those sorts of things that precipitate initiation of dialysis. So I entirely agree. It's amazing that there's this industry and millions or 1 million people or so, 500,000 in the United States that who we're subjecting to the treatment, but we really don't know what we're doing. Yes. Yeah. I agree.
So this work focuses not on the various small molecules, but actually on a protein modification called carbamylation. Before we get into dissecting the findings in this paper, what actually is protein carbamylation?
Yeah, the reaction of cyanate with sulfhydryl groups on various amino acids is what carbamylation is. It's a covalent bond, and it was recognized back in the 1950s that cyanate was highly reactive and with those amino acids, and so in essence the issue is that urea breaks down spontaneously in a very small degree into ammonium and cyanate, and that was discovered, 50 or 60 years ago. But that cyanate is highly reactive with various amino acids, including amino acids on proteins, including albumin.
Right. So albumin carbamylation is what they focused on here. Can you tell our listeners what these authors actually did and what they found?
Yeah, they measured the levels of carbamylated, that is the reaction of cyanate with albumin, carbamylated albumin in about 3,000 patients with fairly advanced CKD stages 2 to 4 who were in the chronic renal insufficiency cohort, so-called CRIC. And then they attempted to decide whether that baseline carbamylated albumin was associated with one of the clinical outcomes, particularly the development of end-stage renal disease over 7 or 8 years of the CRIC study. So, in essence, they took advantage of the data and samples collected by CRIC to perform this study.
And what did they find?
Well, they found that carbamylation was associated with a number of things. As you might guess, it's associated with the urea levels. But most importantly, they found that even adjusted for urea levels, it was correlated with poor outcomes, namely the development of end-stage renal disease. So they tout this as a marker for the progression of renal disease, and it may well be. Exactly how that would occur, we don't know, but we have some ideas.
Right. So the first point that often comes up when you have a biomarker is this actually useful for prognosticating? Now, you discussed that some in your editorial. Can you review for our listeners what your thoughts are on carbamylated albumin as a risk factor?
Yeah, I think it may well be, and it may be something that's readily measurable, more measurable than, say, protein intake. As probably all the listeners know, there's been a large back and forth over the last 30 years of whether higher protein diets lead to more rapid progression to end-stage renal disease. And I think that issue has not really entirely been settled, but carbamylation would be a marker for that. And if it is true that higher protein intake does accelerate progression to ESRD, then it could be useful. I think the thing we have to be cautious about is that, and this gets into the area of statistical predictions, which I'm no expert in, but this gets into the area of whether these kind of risk factors are useful as predictive determinants. And in the cardiovascular field, which has worked with risk factors for a long time, it's become clear that many of the things that have a high relationship to a bad outcome, like myocardial infarction, don't help much in determining prediction for risk. So I'm a little cautious about whether this carbamylated albumin will be ever included in the renal failure risk prediction equations that we all commonly use.
Right. They actually did a C-statistic calculation, and it found it went from 0.88 to 0.89. So it with that particular statistical test, it didn't do much. But still, back to the question of urea. As you mentioned at the beginning, we're using urea all the time as a measure. Both BUN over something or other creates a sense of urgency to dialyze people, and KT over B for urea is still used as a measure of dialysis adequacy. And yet a lot of data tells us urea isn't what causes uremic symptoms. Can I ask you, you know that literature better than anyone, can I ask you to comment on that?
Yeah, I think what you said is correct. There's a classic study done, I think, at the Mayo Clinic back 50 years ago, and published in Mayo Clinic Proceedings by Bill Johnson. And they actually did something that couldn't be done today. They dialyzed people with ESRD against urea baths. And so they got their BUNs up to over 100, and in effect were adding urea to these people. And they saw very little. There was a little bit of nausea, etc. So some mild uremic symptoms or symptoms that you could attribute to uremia produced by adding urea back in the dialysate, but they were pretty modest. And so I think we would all take the point of view that, or many of us, that urea is not the central toxin in uremia. On the other hand, it is true that with the poor dialyzers that we're using, or that Scribner was using 50 or 60 years ago, they didn't remove a whole lot more than urea. And not that we do a whole lot more today, but in any case, they did relieve a lot of the uremic symptoms. So there may be something that's in that range, small like urea, but I think as best we can tell, it's not urea itself that's engendering these uremic symptoms that precipitate dialysis. Another point you made is that, at least in my clinical experience, people often get very excited when in conventional measurements, the BUN, milligrams per deciliter, exceeds 100 and start dialyzing people, and whether they have symptoms or not. And so I do have some concern that in this paper, it's really just the carbamylated albumin and its progenitor, the urea levels, maybe leading to dialysis, which by ordinary symptoms wouldn't necessarily be done. But
right.
That's my answer.
An intriguing suggestion these authors make in their discussion is that measurement of C albumin could serve a bit as something like a hemoglobin A1C, as giving a kind of integrated or time average measure of urea exposure over a longer period of time. I thought that was an interesting idea, given that urea fluctuates both with dialysis adequacy and, as you mentioned, with protein intake. So is this potentially a useful research tool?
It could be. I mean, it could be. And these authors, the particular paper we're talking about is I don't know if it's culmination, but it's one in a series that Dr. Berg in particular has worked on over the last 10 years or so. And it would be very interesting to see what the differences are in, particularly in studies where there were known differences in protein intake, like the old MDRD study. But I think the short answer is yes. I think you're right. It would serve as a marker for, call it, time averaged urea or protein intake, since protein intake is the major determinant of urea levels. And I think it is true that back, 40 years ago, when hemoglobin A1C was first developed, the carbamylation of hemoglobin led to some kind of problems with the assay. I believe that those have been ironed out now, and so hemoglobin A1C is no longer dependent on or influenced by or misguided by the urea levels. So, but at one time it was, and as you mentioned, hemoglobin A1C is widely recognized as a time average glucose monitor. So I think carbamylated albumin is likely to also be a time averaged marker of protein intake and urea levels.
Okay, so much to think about here, and still a major unsolved problem of nephrology. What causes uremic symptoms? I'm sure the answer is going to be that it's multifactorial, but certainly the fact that cyanate can mess up a number of proteins at relatively low levels, but nonetheless, perhaps at the edge of biological significance is an intriguing part of this work. So, Tom, thank you very much for joining me for this conversation, and thanks to our listeners. We hope this discussion helps you intrigues you to look at the work and helps you think critically about some of the studies that we published. And again, thank you, Tom.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.